A little picking and choosing here. So I'm on number 22 from yesterday's handout on the neurology stuff. Number 23 talks about the evaluation of simple syncope. Simple syncope already says, it implies that it's not a big problem. A neurologic exam, don't obtain imaging studies when you have normal neurologic exam and simple syncope. Although, you know, sometimes we're not so sure. I got a paper back from, I'm on number 23 here, page 54. 224. Thank you. So this is their goal, however. There was a study done at Yale back in 2009, 2,106 episodes of syncope in patients over the age of 65, which are, you know, kind of makes you more concerned with, when you get up in that neighborhood. And they looked at what was the yield of imaging. 63% of the patients got a head CT in this study. 10% were abnormal. 2% of those abnormals resulted in affected the diagnosis. May not affected the treatment, but affected the diagnosis. More importantly, 7% had an MRI. Of the MRIs, 30% were abnormal, and 13% affected the diagnosis. So now whether the neurologic exam was pristinely normal is another matter. And I think one of the reasons we sometimes do imaging is because we don't feel very confident that our exam is that neurologic exam is just perfect. And so if we're got some concerns, you do this imaging. These guys found stuff in patients over the age of 65. So I can't go to the mat on that one. 25 is don't do imaging in uncomplicated headache. This is American College of Radiology. So this is a radiologist telling us not to do CTs in headache patients. The significance of this recommendation is that CMS, I don't know if you know this, CMS basically has a quality measure specifically interested in the number of CTs that are done in headache patients in the emergency department. American College of Emergency Physicians opposed that very vigorously. They said that the data being used to assess whether CT would be appropriate or not. See, what they've started out as doing is saying, just tell us how many people that have a diagnosis of a headache get a CT at your place. They make no value judgment on it yet. The concern was that the way that they were collecting the data would not allow them to actually make reasonable judgments about the appropriateness of those CTs or not. And to prove that, ASEP initiated a study. It was done by Dr. Scher in the Annals of Emergency Medicine, published in September of 2012, a recent study, basically, where they actually looked at charts of patients who had CTs done for headaches. And 65% of the patients in this large record review had indications for imaging that were not identified by the administrative data that CMS was going to use to determine if your CT was appropriate or not. So they say, if you look at the charts, you'll find the data supporting the use of CT in these patients. If you don't look at the charts appropriately, you will not find it and you will not be able to make the right conclusions. However, ASEP made this pitch. Here's the study that shows it's not going to work. Basically, CMS said, we're doing it anyway because we're really concerned that you're doing too many CTs in headache patients. And remember the Brigham and Women guys. I'm just going to remind you of 38 emergency physicians. When they looked at head CTs for headache, the range of getting them, one doctor, 15% of his patients got a CT for headache. Other doctor, 62% of his or her patients got a CT for headache. And remember, not related to the level of experience of these physicians. So what they're after is we cannot have you doing this kind of variability here. Maybe our measures are not good enough and they probably are not in terms of how we determine that. But the fact is, you're all over the dartboard on doing this, and we got to work on this. 26 is don't use benzos or other sedative hypnotics in older patients for insomnia, agitation, or delirium. There's just a ton of literature that says if you do that, you will facilitate their death. They have more hip fractures, more falls, more motor vehicle accidents leading to death, more than double than older patients that are not taking benzos. Benzos are in the Beers criteria of drugs that older patients should not be taking. And as an aside, you have these people who are Alzheimer's patients living in nursing homes of sorts, and they're wandering around, and they're combative, and it's hard to control them, kind of thing. And there's such an attempt to give them big-time antipsychotics, just to snow them, so they stay in bed at least. If you do that, you will kill them as well. The data on antipsychotics in dementia basically makes it real clear that they will die a lot sooner. Whether that is good or bad is another issue. Ophthalmology, there wasn't anything there I thought of interest. So we'll switch over to the new guys. Orthopedics. Numbers 1 through 3 deal with back pain. The American Academy of Family Physicians says don't do imaging for back pain within the first 6 weeks unless red flags are present. The North American Spine Association says the same thing, and American College of Physicians says the same thing. They're all trying to get off back imaging in early musculoskeletal pain. Now, we did a talk, I think it was maybe last year. The conclusion of the talk on back pain was the only thing that you need to know are the red flags. If you know those, then you would pick up more likely than not that people who had serious problems, and that when it came to treatment, it was pretty much whatever you wanted to do, it wasn't going to matter. You could give them PT, those kinds of things. All of those things have been compared ad nauseum, and there's just no magic bullet, mostly just time. So under number 2 has all the red flag cases that are listed there. Of course, I don't like the idea that if you have a person over the age of 50, automatically that person's allowed to get a imaging of their back. What do you think, like they got 1 foot in the grave or something like that, over 50? So no, I didn't like that one at all, but there's usually one in there that has some kind of arbitrary age limit. And absolutely, when you talk about musculoskeletal things, like I remember this older guy, he fell off the toilet and got wedged between the toilet and the wall and broke his neck. So, depending on the age of the patients and their osteoporosis. Number 4, that's a given. Back pain, get them up early, mobilize them early. Don't let them get detuned. So this is, you're only allowed 2 or 3 days of bed rest in these cases, and out you go. Talk about number 6. This is just honestly typical of some of the stuff that ACEP said. Oh, okay, we'll do choosing wisely. Here's one of our 5. They say don't delay engaging palliative and hospice care in the emergency department for patients likely to benefit. Isn't that apple pie and mother? Is somebody going to argue against that kind of thing? This is one of the 5. You only have 5. We're only going to give you 5. Give us your best shot. This is okay. You just blew one of your choices here. There is this move for palliation and symptom reduction and those kinds of things in the emergency department. It's a great idea. And in fact, we have a paper that we just did recently that looked at palliative care initiated in the emergency department, and the hospital length of stay was less when it was initiated early. And so it really is a very supportive paper. And I think that we are the people that should be able to initiate this. Number 7, pediatrics avoid IVs before doing a trial of oral rehydration. Well, the last talk of today is about that. The literature says American physicians are way too anxious to start IVs in dehydrated kids, that in fact mild and moderate dehydration is the sippy diet, and severe dehydration, which is the IV, is rare. And so these little kids who are minimally dehydrated, and you're trying to poke here and then trying to start the IV, and the kid's crying, the mother's crying, everybody's crying, kind of thing. No, sippy diet. And we'll get into the more specifics of that later. Don't get too excited about number 8. Don't diagnose or manage asthma without spirometry. Yeah, I don't. You know, they used to have this thing where they wanted to bring spirometry into the ER, and then you can go home. If you blow in it and you pass a certain number, you can go home, and if you don't get that number, you're still... But I think one of the problems with that in the emergency room, at least in my experience, is these people generally are loaded with steroids. And those steroids have not going to kick in the emergency department setting. They're going to need, 6 hours, maybe to make some kind of manifestation. So my always sense was these people are going to actually get better over time than they are now, because these steroids they've gotten are going to do something, but they haven't done anything yet. Don't order chest x-rays in kids with uncomplicated asthma or bronchiolitis. There is a literature that says a lot of those kids get radiated too frequently. Nobody's going to argue with that. Anything else interesting here? The one I thought was kind of interesting is number 12. Don't use continuous pulse oximetry routinely in children with respiratory illnesses unless they are on oxygen. That's kind of interesting because, our nurses used to glue that thing to this kid's finger pretty much all the time, no matter, and if it was 96, that would stay there during their entire visit. That once they taped that thing onto the kid's finger, and it was like, what's the point of that? Couldn't they just put that clothespin on and say it's 96, stop, okay?
Because you get reimbursed for continuous pulse ox.
No, don't tell us that they would do it for ulterior reasons. Well, I didn't know that. It makes sense that you would get potentially paid more for it if you needed it. These guys say you don't need it. If it's normal, don't put it on permanently, because if you do, look at the consequences. They basically say use of continuous pulse ox has been previously associated with increased admission rates. Well, maybe they're sicker. Who knows? But they also then talk about 13 and 14. There's 3 societies asking you to back off on this preoperative chest x-ray stuff. American College of Physicians, American College of Surgeons, American College of Radiology, all are saying 13 and 14 there's no routine preoperative chest x-rays. Don't aid and abet. If they're going in for something really minor, we're going to pin something or something straightforward. It's a 35-year-old, has no lung disease kind of thing. And it's going to be hard to break that, because so many hospitals, we have to go for preoperative testing. You ever see these people? They're getting a cataract taken out, for crying out loud, and they have to go in for preoperative testing. They don't need preoperative testing for a cataract operation. They're awake, basically. Here's a few drops, 20 minutes, car payment. So, you're going to have I do think, though, that somebody has to begin these initiatives at the hospital. And if you've got a nice, stable position at your hospital, start becoming a pain in the butt. Now, if you don't have a nice, stable position at the hospital, you just kind of don't say anything about any of this stuff and do your job, because you're going to get your butt fired. That's one of the problems in emergency medicine. I mean, there is this potential of losing your job in some settings that is a little unfortunate. Now, the last 15, 16, 17, all about the approach to imaging, chest x-rays, and VQs. Remember the last 4 papers on the variation? We're all hitting on this idea of you got to follow the protocol. Low clinical risk, negative D-dimer, stop. Low clinical risk, positive D-dimer, image. That's it. And 4 papers saying half the time people were not following that. So here are 4 societies saying, please, please, please follow the protocol. This protocol they're talking about in number 15 is exactly the one I just mentioned, exactly the one that has been measured 4 times in those studies. So we're talking about the American College of Chest Physicians, American Thoracic Society, American College of Radiology, American College of Physicians, all basically say, please follow the protocol. 18 is an interesting one. This says if you have a young woman who you think may have a is being evaluated for a PE. Do a chest X-ray, because statistically it's going to be normal. Chest X-ray is normal. Do a ventilation or perfusion scan. Some people just do perfusion without the ventilation because the chest X-ray is normal. That will substantially decrease the radiation to her breasts. So this idea of everybody getting CTPA, no, this young woman subset number, Society of Nuclear Medicine. Well, it sounds like they have a vested interest. They're the Society of Nuclear Medicine. They want to, okay, do that study for them.
Do they differentiate high risk young women from the medium risk? Or, I mean, I come from there when that's all we did was VQ scans, and it was kind of a shit study. You got to.
Well, no, yes, that is true. And when they were read the old way, there was a huge number in the intermediate risk group, which means you had no idea what the heck. The way that they're reading them now is yes, no, yes, no. That has been shown to be, it forces them into a box, the radiologists. But before, the gray zones were killing them, and so everybody was getting a VQ scan, came out indeterminate or something to that effect, and said it was, so 60% or so were like not helpful. When they're read in this new manner, and it'll be interesting to ask your physicians if they're reading it, how they're reading them, because right now the reading is yes, no. They don't get the gray. Oh no, no, they can't do that. You say you're a little behind the times, doctor. Wounds, don't routinely use topical antibiotics on surgical wounds. Well, we don't have surgical wounds. We don't have clean surgical wounds, but I do want to take just a second to tell you about these papers that are, have you seen the commercials that say, Neosporin makes wounds heal faster? You see those commercials? It's like, why would we not put Neosporin on a wound if that wasn't true? You see, I see them all the time, and the reason that I'm sensitive to them is because in 1979, most of you will remember this study, November 1979, in the Archives of Dermatology, they had a pig study, and they made lacerations on pigs, and they sewed them up, and they put stuff on top of those wounds. Furosin decreased wound healing by 25%. Silvadene increased wound healing by 28%. Neosporin increased healing by 25%. Now, if you can increase the rate of healing of a wound by 25%, would you not put that stuff on the top? It's not about infection. It's about it's about the milieu that you've created on the top of the wound that allows these little fibroblasts to get together. And it's not, and these guys basically saying, oh, no, Neosporin, you have bacitracin in there, and that's going to cause a skin reaction. I think it was grossly. At our hospital, for 25 years, all the wounds that we sutured, we took out the sutures, we did the wound care. We wouldn't send them back to their family doctor for suture removal or something like that, or their internist is even worse. We figured, what the heck do they know about this stuff? They don't probably even have a scissors in their office to take these things out. So we'll do it. We did the job. We'll finish it. And so this was done routinely. I can't tell you ever seeing a case where I thought there was any kind of reaction to topical Neosporin. And if you really want to be a purist, do polysporin. Polysporin doesn't have that neomycin in it. Now here's a really important one. Here's number 2 from the American College of Emergency Physicians. Again, a real softball. Avoid antibiotics and wound cultures in emergency department patients with uncomplicated skin and soft tissue abscesses after successful incision and drainage and with adequate medical follow-up. Everybody knows that treatment for abscesses is drainage, and that, antibiotics are not the answer in those cases, and getting cultures is a waste of time. It's going to stow staff in the vast majority. Oh, okay, MRSA, okay, no, what are you going to do about it? So this is kind of like, it'll be more interesting to say, and limit the use of packing, or if they had gone the next step and given us something a little bit more interesting, but I have to say that was a kind of softball too. Down at trauma, 21, trauma. CT scans are not necessary in the immediate evaluation of minor head trauma. So says the American Academy of Pediatrics. They're asking about using the PCARN stuff that Dr. Henry talked about. Approximately 50% of kids who visit emergency departments with a head injury are given a CT scan, obviously many of which are unnecessary. So they're asking us to back off, use criteria, and they specifically talk about clinical observation prior to CT decision-making for children with minor head trauma. I think that's a great idea. The one paper in here that looked at observation, I think, had multiple deficits. I think a period of observation will make the parents, hey, they're being observed by the parents, see that, that's okay. Johnny seems to be doing, Mom, do you think Johnny's doing better? Mom, yeah, I think he's doing better. Everybody's in agreement. Okay, get the hell out of here. 22, avoid CT of the head in emergency department patients with minor head injuries who are at low risk on validated decision rules. That's from the American College of Emergency Physicians. Avoid CTs of the head using, that's the kind of the same thing that they said before. The one in kids is PCARN. I don't know what they're talking about in adults. I don't know of any kind of validated thing for doing head CTs in adults. You know, Jerry, the Nexus group did the head thing. Even Jerry will admit that that was a mess. Didn't come up with the right answer, and that there have been no validated decision support instruments for heads and head CTs in adults that are of any value, because their sensitivity is not good. You're going to miss stuff. It was kind of like they did the Nexus study for the neck. That turned out real great. Then they did Nexus for head. Didn't turn out so great. So that's 22. Oh, look at the 23. Avoid whole body scanning. This is American College of Surgeons asking its brothers and sisters, hey, back off. Avoid whole body scanning in people with minor or single system trauma, like, you know, maybe a musculoskeletal kind of thing. They do acknowledge that the aggressive use of whole body CT scanning improves early diagnosis in polytrauma. However, significant radiation, as well as costs, in the setting of low energy mechanism of injury and absent physical exam findings consistent with major trauma. You know, I do know people going, they go to the trauma system because they had some mechanism of injury that qualifies them to go to the trauma center, that all clothes are cut off with these scissors that cut through pennies, and the person run through some scanner with the most minimal of physical examinations. It's almost like automatic. Did anybody examine this patient in particular? Was there any examination warranted in terms of the imaging that was just done? And I hear stories about that. Does that ever occur at your hospitals, that they're just scanning people with a minimal review of a history and physical kind of thing? No, not at your hospitals. And there's this stuff about don't administer packed cells. This is this thing about the blood. And so they're trying to suggest that, you know, don't be anxious to give blood in a stable patient. Hemoglobin is 6. Don't feel the necessity to do this. Because one of the things that they talk about there, hospital mortality remains lower in patients randomized to a lower hemoglobin threshold for transfusion versus those randomized to a higher hemoglobin level. Blood is not a great thing to give if you don't need it. So they're asking, don't do this casually. 25 is basically said, it's the colloid crystalloid thing. It says we don't really know any difference. Urology ones, 26 and 27 are the same. Don't obtain a urine culture unless there are clear signs and symptoms that localize the urinary tract. This is about this asymptomatic bacteriuria business. And we did a paper on that about 2 issues ago. And it basically gave residents a quiz on what they knew about asymptomatic bacteria. And some of those residents had already completed an infectious disease rotation, so you thought they would probably get the answers right. And their answers on this quiz was abysmal in terms of what they knew about asymptomatic bacteriuria. The long and short of it is, asymptomatic bacteriuria is just that, asymptomatic. Yes, you can have bacteria in your urine, and you can have some pus cells in your urine. You can have bacteria and pus cells in your urine. But unless you have symptoms consistent with an infection, that is called asymptomatic bacteriuria. And the people who are most concerned about that are the guys who, or gals, who run nursing homes. Because the elderly patients seem to have this found. And why do they have it found? Because they go into the ER, they're sent into the ER, and grandma is just not doing well. She's got the dwindles. Would you check her out, doc? You know, we look all over, and you do the 15 blood tests, and you check the urine, looking for some kind of an occult infection, and the lungs are clear. And there you see this white cells and some bacteria in her urine. And say, aha, here is the problem. Grandma has a UTI. Now, what if grandma was alert and is able to say, no, it doesn't hurt when I pee. No, it doesn't. I'm not peeing more frequently. No symptoms consistent with a urinary tract infection at all. That would be called asymptomatic bacteriuria. And that should not be treated. And you haven't found the reason that grandma is not doing so well. And so don't inappropriately blame it on this asymptomatic bacteriuria and pyuria.
Is there a discriminatory level in the white cell count in those either demented or unable to tell you patients?
No, we're going to talk about those. Those are next. Unless a person can tell you about their symptoms and they say, no, they have no symptoms consistent with UTI. So we have a mismatch here. We have some data of what's in the urine, and we have information that says there's nothing wrong with my urine, doctor. Thank you in terms of how I feel. The next question, though, is what about the demented person that cannot tell you about whether they have any urinary symptoms? In those cases, you need to kind of, first of all, it would be helpful to ascertain whether there was some findings consistent with an infection. Is there a fever? Is there a white count? Is there, they're not going to tell you they have a fever or chills. In those cases, that urine probably should be cultured in those cases, and in fact, that may be a urine infection. So you're looking for two things. Number one, you're looking for signs of an infection. Fever, white count, yeah, looks like something going on here. Culture urine, yeah, it's got lots of bugs over 50,000 or whatever the threshold is going to be. It's more difficult in those situations, but I see my colleagues prior to when we started getting annoying on this, it's trolling. It's trolling for problems in grandma. Find why is grandma not just doing as well as normal? You have no baseline, so it's hard for you to determine what is grandma normally like, and we attribute it to this asymptomatic bacteriuria. And the key is that these people have to be able to talk to you and tell you that no, I'm okay down there, kind of thing. And if they are, you have not found their problem. And the last thing here is about Foley catheters. 28 and 29 are both about Foley catheters. And it would, this would be a really nice project because the literature, I've seen 3 or 4 papers, they said, yes, Foley catheters are most often put in the ER inappropriately in terms of ratio-wise. What can we do about it? They do a little search of the literature. They say, here's the criteria we're going to use. Does everybody agree on these criteria? Yes, we do. We're going to agree on these criteria. And it was a before-after study, bam! The number of Foleys goes down substantially. So that when they're admitted with that Foley in, it happens to stay in now, this idea of getting these urinary tract infections for which Medicare is not going to pay you. But that's not the real issue. The real issue is they didn't need them, and now you got a complication that you induced because you put that Foley in for nursing convenience or some other similar reason. So, and those lists of criteria are easily found if you were to do a little search. And then you could say, do you agree with them? Do you want to take one out, add another? But that would be really a no-brainer project. And your hospital administration would like that because they're really attuned to this idea of we need to prevent catheter-induced urinary tract infections. And so the emergency department is taking the initiative here. Wow, aren't they nice? We really appreciate you guys taking that on, because it's an easy thing. You'll win, you'll do it, it'll work. Okie dokie.